My name is Lois Darnell. I'm the wound care nurse at Jackson County Hospital. Been there for 21 years. Haven't been a wound care nurse that long, but was on the wound care team all those years. We had like 2 on each floor, and we would do wound care after we got through an 8-hour workday. Very rough. So anyhow, it went on to where all the nurses decided they didn't like doing that extra, so it got down to hardly any. It got down to about 2 of us left. So our coordinator at that time, nursing coordinator, was Diana Myers, and she went to Mr. Wilson, which is our CEO of the hospital, and she asked him, could we have one nurse take care of all the wounds for the hospital? And he said, oh no, we can't afford that. Well, something came up that he changed his mind. And so I started in 1999. Well, I've been a nurse since 1991. Started in 1999, and I had a big job ahead of me. I had to change the standing wound care orders. I had to train all the nurses, just groups and groups of things. So the first thing I did was make a plan that we was going to get the hospital to have no pressure ulcers at all. Well, that was a big deal because first year we had like 37 hospital acquired, like 1s and 2s. Well, those 1s and 2s, I thought there's no reason for those 1s and 2s. We had stages come in that was 3s and 4s, but that's came in. We didn't cause them. So I got a whatever you want to call it, a little group of people here, there, and everywhere that was my little spies, and we decided what needed to be done. So I found out that, for one thing, on admit, we weren't catching most of the things on admit. So our hospital helped us with that, and our nurses have been for a long time on admit looking from toe to stem. I think we were supposed to have been doing that all along, you know, but it got to the point where JACO and all of them really coming down on the hospitals and what weren't going to pay if we caused those things. So after that 37, that first year, I thought, oh, I'll never get that many down. But we did. We just kept diligently working at it. And the last 3 years, we've had 0.
Oh my goodness.
So, and that's because all of our nurses is helping, you know. They're on admit, they're saying whatever's there. And that brings me to that little card that I passed out to you, that deep tissue injury in stage 1 through 4 and unsuspected or unstageable wounds, that's put out by the National Pressure Ulcer Association. And they went through a long research and program of doing this. And some of the things that they had learned was, why is the nursing homes getting 3s and 4s? All of a sudden they just have a 3 or a 4. Well, they researched and they found out that they really weren't just having them. They hadn't been staging along the way, and most of them starts with a deep tissue injury. I think that's the first thing on your card, isn't it? Mm-hmm. Okay, so they documented and want us to say when there's a deep tissue injury to begin with, document that right on admit if that's what it is. Not document false, but document what it is. And so that's what we started doing. Of course, all the nurses just call me. They're spoiled. They call me and I go and I'll do it. But they go ahead and document what they see. Say like if a deep tissue injury is dark maroon, blistered, all that type of thing, then that's what you want to write down. You see a dark maroon, blistered, blood-filled area, that's a deep tissue injury, okay? So if you document that they came in with this, which they did, maybe, and most of these things that's stageable has got to be on a bony promise. They're not going to be here on your cheek. It might be on your ear. But, you know, on that card, it shows you all the bony prominences there is. So stage 1, what does everybody know about a stage 1?
It's red.
Did I hear somebody?
It's red. It's not.
Okay, okay, how do we proceed to know whether it's really a stage 1 or not?
Is it tender to the touch?
Tender to the touch, warm to touch, and if we blanch down and it doesn't come back, and it's still red and deeply red even with the blanching, when you blanch with your fingers, normally if it's not a stage 1 and it's just pressure, it'll come right back or slowly come back. But when it don't come back, that's actually a stage 1. And that's what you should say if that's what you're documenting, you know, when you're in charge of doing that. Like I said, our hospital just has me do the staging. That takes a lot of pressure off of everybody's back. But I want the nurses to go ahead and document what they see. You know, well this, so if they document what it says on the back of that card or similar to what you see, we're all going to know that, okay, that sounds like a stage 1. Yes?
Do you want them to document stage 1, or do you, okay.
Okay. That's what I was saying. At our hospital, I do the staging. But, I mean, it's in your mind, you'll know what it is, you know, and you can document, well, this was a reddened area, warm to touch at the sacral area, does not blanch. Okay, that's telling you right there that it's a stage 1, but you're not actually writing it, okay? So I have a really, I don't know whether I can show this picture or not. Whether you can they see it? Can you see it? Can you hold it? See it? This is actually a stage 1 that came in, and what I had the nurse do was put cream on it and keep her off of it for the next 3 hours, turn Q2 and keep her off of that area, and that area went all the way back to just pink. So, but it still stayed that way. But what I'm saying is if you have something red on any of the bony prominences, if you'll turn them and you watch that area for the next 2 hours or so, and you'll just see it diminishing most of the time. Sometimes you're going to have a bad one and it's not going to matter what you do, okay? Now, I just got through telling you all about that suspected deep tissue injury. Well, I have a real live picture here. This lady came in, she had a dislocated right total hip. She had arthritis, rheumatoid arthritis, and of course she was all contracted up like this and in fetal position. So when she came in, and I had just gotten those cards, that's an older picture, but it's such a good one, I wanted to go ahead and use it. When she got in, I went right ahead and put the Biafine that I like so well and the foam pad on her, kept it on there. And what date is on that picture?
7/25/07.
Okay, so 5 days later, this is what it looked like. That's as long as I had her in there. Okay, now, my whole purpose of showing this to you and telling you, okay, we said it was a suspected deep tissue injury, okay? So that injury is going to evolve into something bigger. Okay, the picture that's passing around right now, that's day 5. So day 5, it looks a little better, but you see that it's breaking, the skin's coming off, it's loose skin. All that dark area is loose skin and it's going to come off, okay? No matter what we do, we could suspend her from the roof and not have any pressure at all. It's already dead, so it's going to come back. Did those girls didn't get to see it. I don't know where the last picture was. Right there? Okay. Are you being able to?
I was trying to get it on the
Oh, okay.
screen.
Okay.
I don't know if we will or not.
It's not coming. So After we got it to that stage, the stage 5, where's the 5-day picture? Right there? Okay. Here's 17 days, I think. We sent her out to the nursing home. I called the nursing home. I gave a report. I told them, I said, this lady has a suspicious deep tissue injury, and it's going to turn into at least a stage 3. And they just thought I was crazy. They actually just smiled at me, you know. That there is a stage 3. That's the stage 3 you're looking at. Stage 3 doesn't have any bone muscle showing. It's just that subcutaneous fat. So, I mean, they didn't believe me, but I went out there and followed through to make sure they understood what it was. So
if it's deep tissue, that means it's
going to turn, yes.
Okay.
If it's deep tissue injury and it's went very far, it will either end up being a 3 or a 4. This one just happened to be that I caught it when she was in the major sickness and in the hospital. So it started, the healing. Well, when it was kind of funny because when the nursing home went out and came to see the injury, why I undressed it for them, they took it apart and they said, oh, that doesn't look bad. Okay, whatever you say. It's going to be a stage 3 or 4. That's what I told them. You know, yes.
So you're saying that if it starts with a deep tissue injury, that it will usually come out to a stage 3 or 4 whenever
Especially if it looks like it does there.
in here?
Because see, you've got your blood-filled blister. You have your dark maroon area. You have it over a bony prominence. So all those things connected, see, just makes it. It's just a given. Now, if that had been maybe on a hip, not a hip, but a buttocks, I probably could have cleaned that completely up without it turning. But you don't never know. You never know. It's going to, because the tissue's dead, is what I'm saying. Because that tissue is dead, it's going to go ahead and break down. Maybe if we catch it in the very beginning, it won't turn as bad as what some do. But after that, the nursing home started doing what I was doing to the deep tissue, and I'm glad they did, you know, because that helps. Okay, I have another picture here that's a heel. And heels are real bad in nursing homes, especially if they're sick, you know, and they don't have good nutrition. All those things going on. I can't get on this chair. It's rolled away from me. You got runaway chairs.
Yeah.
So I went ahead and put that in there because, see, that's fluid filled. They used to, and I think they try to still sometimes, stage that as a stage 2, as a blister as a stage 2, but that's blood filled, so it would fall under the deep tissue injury.
How long did it take to get like that, like with no movement?
You know, if they don't move the patient just has that heel laying there, it can break down like that within 24 hours. Just depends, you know, what that person's laying on. Are we treating them with something and putting socks on them so that they don't have that surface rub? It's just it's a guessing game, really, of what you can and you can't do. My preventive care that I do at the hospital is one of those things is we put Granulex and barrier both and socks on. If they're really, really red and they look like a ripe tomato, within 2-3 days they're not that way at all. But you know, I have different treatments for different things, and it's just, it's a give and take.
Do you learn that with experience, or does the hospital have a protocol or something?
I have protocols, Lane. And anytime anybody needs to know anything, I'm full of information. So you can call me. I have a card and my name, and I have a wound care book on each floor where I'm adding stuff all the time so that you will know, because new nurses, when you're bombarded with taking care of a patient and your IVs and you're doing this and you're doing that, you think, oh, wound care too? That's true. It's very true. Okay, here is a stage 3. This one, you couldn't get that to work?
It wouldn't show.
The stage 3, as you see, you can't see no bone. You just see slough, and you see subcutaneous tissue. That's a stage 3. I had put a vac on that and cleaned it up. So that's why, that was cleaned up. You ought to have seen it before. It's pretty rough.
What's the,
Slough is the yellow stuff that's dead. Sometimes it can be yellow, gray, black, soft, stringy, all kinds of different nasty stuff.
Do y'all know what a vac is?
Yeah, do y'all know what a vac is? A vac is a wound, it's called a wound vac, but KCI puts it out. I think it's in one of your books.
Yeah.
Okay.
Yeah.
I
heard
use,
about it this morning.
did
Okay,
you?
sorry.
Okay. I use that quite often. I use it on surgery patients, I use it on wounds of this nature. And I also use maggots on 3s and 4s, because you can put maggots there and it'll clean it out within about two deals.
Oh, you're talking about maggots that are specially grown for this kind
Yes,
of birth.
they're
not just-
sterile grown. No, I can't go out and get them out of a cow. They're specially grown. I get mine from California, and I order them through the pharmacy. Comes within overnight, and we put the first application in the wound and leave it for 48 hours. Clean that out. We have a special way we have to put them in, special way to keep them in. We have to net them in, and it's amazing. I've got a wound here that I'll show you what the maggots did.
Did you have much trouble with the docs letting you get that to?
The maggots? Don't have any trouble with any of the docs. All I
Good.
say is, Dr. K, I need, you got it. Dr. Leverett, you got it. Whatever you want to. So I have real good rapport with all the docs. So if you have problems with any of the docs, come get me. I'll help you.
How long do they survive those maggots?
How long?
Yeah. How long do they survive when they ship them?
Only the 4, well, they are put in cold packs. They're put on a cheesecloth, and they have sugar water that they eat all the way here. And it's in cold. That's why they have to get them overnight, because,
How long can they live indefinitely after you put them in the wound?
no,
No?
only 48 hours, and we gotta take them out in their big, fat, squirtly things. But you know, the bed looks beautiful. And so all I'm seeing is this bed, you know, and the nurses around me go, you know.
So you,
I know, it's kind of gross. But it's really a humane thing to use on patients. Now, if they're younger patients or patients, you know, that's 40s, 50s, whatever, you have to really talk them into wanting to do that. But the older people, oh, honey, just do whatever. And they're okay with it, you know. But one young diabetic man I had, he was 49, and he said, I don't know if I can stand those or not. And I said, well, would you like us to try? Because I said, we're going to be months trying to get all this necrotic tissue off. The surgeon had already debrided it, and it just went all black again. Just dead. Diabetics don't have that circulation. So guess what the maggots do? When they're eating, they're drawing that circulation to that foot. Same way with the vac, they draw the circulation. So once we got the maggots to clean the mess up, we put a vac on, and most of them I could heal within 3 months. Now I can't keep them in the hospital that long. So that's another tribulation we have to do. I either have to send them to outpatient physical therapy, and then they take over, or if the doc doesn't want them to, I have to go over there and take it. But most of the time I can transize over to PT, and PT's real. They're good with wound care too. Not all of them like wound care, like everybody, but they're good at it. They can do vacs, they can do all those things. I have a stage 4. It doesn't look much different other than the tunneling. It's really, 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 really deep tunneling. This little lady sat in her recliner all the time, and her husband was just the sweetest thing. He constantly was making sure she had food and everything, and when she came in her pre-albumin, which is another thing we got to go over, pre-albumin is what the half-life of your nutritional eating habits are, okay? If it's low, and hers was like 6, the high is 19 to 45. So I couldn't imagine, she was a large lady, and I couldn't imagine what she was eating, so I quizzed the husband. The husband said, I feed her good. I have her pop, I have her ding-dongs, I have her candy. I said, okay, what kind of protein? Yeah, what kind of protein are you feeding her? Well, she doesn't like anything but the stuff I bring. And I said, well, I want you to bring her peanut butter, I want you to have her meat and fruit and vegetables and leave all that other stuff off. And he says, oh, she's gonna be mad. And she probably was. But that's just, that's the way it is. Has anyone heard about the Kennedy ulcer? Have you read about it in your books? A Kennedy ulcer is also called an end-of-life ulcer. End-of-life is where, like, the body's trying to compensate, so the blood's all shunting to the heart and the liver and the lungs, the important things to keep us alive, right? So it won't shunt towards the coccyx, it won't shunt towards the feet, and you may see discoloration from your extremities and that coccyx. Well, the coccyx is the noted place where they usually happen to have the Kennedy. This is one, this patient, she had it pre-existing on admit, so we put an Aleve foam pad on her, and it was opening up. This was on the 8th of March, and she passed the 15th. So sometimes that's an indication that the patient's dying. So if you ever see things like this, well, you might kind of question and look at the labs and see what's going on with her or him, either one. Here's just another different one, and she died. As you see the blisters, I marked the blisters. The blisters is where you will blister when you have no circulation. Like the legs will blister, you'll have weeping and all those kind of things. So she died in 3 days.
When you see an end-of-the-life blister, at that point, is it too late to do anything?
You go ahead and you treat it like you would. I always put my famous stuff on all those things. But yes, ma'am.
Oh, go ahead.
It's okay.
So if it is end of life, and are you gonna know it is because it's not gonna heal, or so that would be like a sign of it is end of life?
And sometimes they will start like overnight, or there'll be like maybe a little pin point, and you go through the whole shift and it's still a pinpoint, and by the next morning it's like a quarter. And you'll hear people say, oh my gosh, it wasn't there yesterday. Well, that's another indication that it's an end of life. This little lady, I've got some gross looking pictures here, girls. This little lady died with a yeast infection and a Kennedy, and she had a blood sugar of 1400 brought into the unit. So she was just a disaster waiting to happen.
I've never seen anything in any of our books about a Kennedy ulcer.
You haven't?
I've never heard about either.
You will find it on the internet. You'll find it on the internet. Okay, I was going to go ahead and show you the incontinence excoriation. There is differences in between stages and what's called incontinent excoriation. I've had people come in and, their bottoms just look horrible. They'll have mixed things that's going on, like a yeast infection and urine. Everything's just stooling. This one right here. This is what she looked like when she came in. This lady passed away also, but her husband said he'd been putting Granulex on her bottom. And I said, oh my goodness, I bet that hurt. So I did the treatment, and this was in 5 days, I think, maybe 3. What's the date on that one there?
This one is 3/21/12.
3/21/12. And this is 7/27. So she passed away, but see, you couldn't stage that because she had had vast diarrhea. So the diarrhea and the urine excoriated her bottom and opened it up. So it was a case of he said, she said, whatever. But it was from incontinence excoriation. So that's what I documented it as an IAD, incontinence associated dermatitis. And then what I was going to do, once I got that halfway good looking, I was going to go ahead and stage just the little open places as, caused from incontinence excoriation. And that's what it was caused from. I mean, there wasn't nothing else that caused it. That's what caused it. Does everybody know what a blood clot is? Have you ever seen it on a person's leg? I'll just pass this whole thing around. This lady hit her leg on her wheelchair and made this huge hematoma. Okay, when she made the hematoma, it just grew. I mean, just zapped. So the doctor, when she came in, he debrided this. That's the whole leg. I mean, front and back. And so he debrided. That's the first picture that he debrided. And I had to put a vac on that. He says, put a vac on that and get that fixed. And so I put a vac on it. And as you can see through the pictures, she granulated up really well, pretty. Nice granulation. So then next he says, well, what are we going to do with it? So I said, I want to graft it with pig oasis. And that's what we did. We grafted the whole cover. What that does is, it's like a thin onion skin, and it covers and keeps the infection from getting in that leg. Plus it lets that leg grow up to that skin and finish. Now, she went to home health, and guess what? The first thing that happened, they macerated it. So I had to go out to home health and have them dry it out for a couple of days, and I just stuck that in there so you could see what they did. You can also get to, they had not cut the treatment that I was doing just right to the size of it, so you see what they did. They just put 2 great big pieces there, and it macerated. All that white is maceration. That's the healed leg, but look how long it took. It took almost a year. She's a diabetic. Yes.
In a situation with the last group of photos, is that painful to the patient? And if so, what kind of
Yes.
pain medicine?
Well, she was on Percocet. That's what she took daily for pain anyhow. But I coaxed her not to take any more than was necessary, because the more pain medicine they are, the slower it is to heal. So she actually only took Percocet twice a day. And she did well with it. So, what the heck? Don't kill it. Yes.
All this occurred from her blood clot that she...
It was huge. The thing raised up. By the time she got to the hospital, it was raised up that much. She lost a lot of blood.
And it just deteriorated her flesh? Is that how it came out open?
Well, the doctor opened it.
To get
He took all the clots out, yes. Took all the clots out, but it was, this next picture is the same way. Same thing happened on Coumadin. So if we don't pad their legs and care for their legs so they don't get hit, same with arms, that's what happens. Here's another one. This is a recent one. But time she hit her leg on, actually, I don't remember what she said she hit it on, but she hit it and had her jeans on. This is debrided. The doctor already debrided it. I didn't get a picture of what it looked like before. She said that it grew so big that when she got to ER, she had to have it, have them cut her jeans off. That's how big and tight it got. Here's another picture. Now, you see all around that edges where the doctor didn't remove that? All that has, and he wanted me to put the vac on. So I went ahead and put the vac on, and I called him and I said, you know you're going to have to debride that stuff. The vac's not going to debride that. And he said, yeah, but I thought you'd get it under, you know, safety, and then we could do it. On the other leg, look what was popping up. Another big hematoma. So I wrapped it from toes to below the knees and kept that under check for quite a while. This is what she looked like when she left the hospital. Here. We don't get to keep anybody long enough to get to see them healed unless I get them out to the outpatient. And I had PT come and debride that right calf so that it would all be, and it looks pretty there, as you can see. Yes, sir.
Can you explain maceration?
Maceration is when the skin surrounding the wound gets so soaked it just turns white. When you see a white area like that, it's so macerated with fluid, which came from that dressing, by the way. If they'd have cut it like it had supposed to be, I'm a creator, I like to craft stuff. But if they had cut it right, well then it would have been okay.
So new skin that forms doesn't necessarily adhere?
The new skin that's there, I think you'll see the last picture, it never looks the same as the normal skin for almost a whole year. It takes a year to mature. So it's still very tender and you could hurt it again. It's not a good thing. I have a surgical wound here that Dr. Shirley, he's not been working lately. You know, he went out for knee surgery, or hip surgery, that's what it was. So he had this lady that dehisced over the knee, got infected, and he wanted me to take care of it. So I did. Let me see where the picture is. Okay, so I was taking care of it for him. Let me just scoot through these a little bit so you don't have to show the whole things. And I got it to where it was looking really, really good. And he said, I'm going to sew that up. And I said, oh, Dr. Shirley, don't do that. He said, yeah, I think it'll heal now, Lois. I think it'll heal. Well, it didn't. It came apart. So I banned him from the leg. And I did. I told him, I don't want you touching it no more. So this, you're messing with my leg. So these are the last 4 pictures I have it healed. Here's, start from there. Guess it's, yeah, 3. And you see how it takes off in this next picture. When I got him to leave it alone.
How can you tell the difference between the new skin formation, the cells migrating to close the wound versus the...
Okay, this next picture will answer your question, those next 2. It's pink, it's real pink, it's different color.
Okay.
You see the difference in the pink, that's all new skin?
Are you talking about the white around the edges?
Yes.
Yeah, I think you're talking about the white around the edges.
Which edge? Okay, yes, that's all new skin growing. That's all new skin growing.
Can you tell the difference between that and that skin that you were...
Maceration?
Maceration.
Because I've been a wound care for a long time.
What's that
And-
word? What's that word?
Practice.
Practice. And here's the final. She even told Dr. Shirley, she said, I don't I just let Lois take care of it. Just let Lois take care of it. She's good at this. Just let her take care of it.
So are you saying that at JCMH here, we are not going to be necessarily doing actual wound care?
Yes, I will let you do actual wound care.
Okay.
Because
Just not evaluation?
But you
Yeah.
better do what she said.
Yes, obviously.
no, I'm not that mean. Just Brenda thinks I am. She and I were friends, old buddies in school.
We went to LPN school together back in
Let's don't tell
early
our age.
ages.
We graduated in 1991. That's how far back it was, wasn't it? Oh my gosh.
Yeah.
This is just another one that she came in and this is actually a skin tear that she received. She has a knee that she has had worked on, and they tore her skin. It was so fragile. And so one of my nurses decided she knew what to put on it, and look what happened. So I had to put my magic formula on there, and then it was okay. Yes, ma'am.
Some of these debridements, would it be considered like a surgical procedure?
Any that has, yes, the hematomas, all those removals, all those were surgically debrided. And it's really hard on these people, you know, when they're old anyhow, and they come in and they have to be put under anesthesia to go get that cleaned up. So it's better if you just don't get anything done like that. If you don't, if you protect your legs.
Do you know what they do of wound debridement? Like how do
Yes, I've been in there several times. They get them all prepped, you know, the whole leg prepped, and then they just take those layers off that's there
how?
with scalpel.
Okay.
It's, are you steady-handed today? We've had some really bad skin tears also at the hospital, and we don't classify our skin tears like this. I make an incident report. Whoever's done this, we have an incident report. And this happened to be PT was walking this little old man, and they had the back belt around here. So if you've got people that you're walking and stuff, make sure that back belt is not against their skin. They had 2 gowns on this little man, and when they set him down, look what they did to his back. Horrible. That's classified as a skin tear. And here, I'll tell you what one of my nurses did. You never can get them all taught right. But she thought, oh, let's cover that up. So she got the largest tegaderm she could find and put over that. This is the healed product. I didn't bring all of the pictures. It healed up really nice. But can you imagine putting a tegaderm over that big of an area?
I know they made them that big.
Ripping off more skin.
Yeah, they pulled up a whole bunch more skin, really bad. I have a new skin tear protocol, so when you ladies and gentlemen come up there, I'll show you all those. I've got them on each side. And what the skin tear is made up of, I like Xeroform. It's a surgical type thing, and you can clean up that wound care, and you can put that on there, and it heals within days. Just heals it. You know what Xeroform is, don't you? It's been long. Don't do this, guys. This is an IV taken out with a little old lady. The stat lock caught, and it tore that. Isn't that awful? That's an awful skin tear.
To prevent that, you can use alcohol wipes for taking off that
I don't-
skylark, like kind of rub and pull.
I don't like alcohol because it burns. But
They've
you,
got some,
Detach
stuff,
all.
what's it called, in that little pink tube?
Detach all.
detach all.
Yeah,
Yeah.
It's
that's what
supposed
you
to
Okay.
take,
be.
take off with, yeah.
So just make this
adhesive.
Yeah.
Yeah, it's like Goo Gone, you know?
It really does detach all.
Yeah,
Well, I've talked a long time, haven't I?
you're fine.
A-
I like it.
Anyhow, okay. Has everybody heard of a parasite, not a really parasite, but it's strep A, which is fasciitis? Have you heard? I know you have. It's skin disease that eats the skin. Well, this little lady here, she cultured out as strep A with that. So here she comes in. This is what her arm looked like. Well, overnight it turned like that. How it turned like that was, she went home and washed it and put some old gooky stuff she had in a tube for years. I think the bacteria was in that tube. So don't use anything old. Anyhow, this is what it looked like overnight. It changed it overnight. Look at it. You see it? So when she got in there, we cultured it, and Dr. K was consulted, and he went immediately to breed it and debrided it. Okay, this doesn't look great, but he's, he had to, this is real superficial, your arm is. So he had to get a lot of bleeders, and he turned it back over to me in PT. Well, all that I read about it was that we have to aggressively debride this daily. So we started debriding it. And I mean, from one day to the next, there would be more yellow stuff back on there. And just horrendous. But anyhow, we got her completely healed. She was just a mess. Sweetest little old lady you'd ever want to see. But she said, well, I just saw all this stuff in my husband's. She had a house and he had a house. They were widows and they had to go back and forth to each other's house. And she said, I just saw that, so I just got it out and put it on my arm.
Well, what was the initial wound? Was
The
there
initial wound was she hit it on the cabinet and cut it right there at the elbow. It was awful.
So this is that flesh-eating bacteria that you hear about?
Is
That strep
different
A.
than meningococcal leukemia, or that's the same thing?
I don't know.
I think it is the same
Well,
thing.
I think this was a strain of it because that's what it cultured out as,
Yeah.
What I think happens a lot of times is they probably don't get that at the moment it needs to be got, like.
It has to be, antibiotics have to be started within 12 hours of the very first rash that appears. So it's,
I think it was, I believe it was Fanco we started with.
yeah.
Yeah, I think it was Fanco. It was awful looking. Is there questions? Anybody got some questions for me?
Okay, I'm gonna sound dumb, but I'm gonna ask you to go back.
That's okay.
You've referenced, I think, 4 terms that I'm familiar with. We did a skin tear, a hematoma, a blood clot, and a pressure sore or ulcer. Are all 4 of those different things?
Okay, now say it again.
Skin tear and hematoma, blood clot, and pressure sore or ulcer, those are all 4 different things? And they're all things that you would specialize in? Okay. I just wanted to make them
The
separate in my head.
hematoma is created from the patient, whatever they've hit. Most of them is just crazy stuff. A table. I have to answer this. Excuse me. Or silence it on which. Ah, I silenced it. The hematomas, the patient usually comes in and they've done it at the nursing home on the wheelchair, on a corner. It just depends on where. But it's always on the legs that I'm getting these hematomas start. It's just